Shilpa, which of these trials is going to be negative?
I first want to point out that the SWOG gap trial closed even right after it was open.
This was your slide. This was your slide,
I know,
isn't
but
it?
that is, I think, from 2 years ago. So,
Okay, Shilpa,
so
which
I
of these
think
trials are going to be negative?
will be negative.
Any of them? Or they all, I mean, is
I
NIAGARA?
think they're all going to be positive.
They're all going to be positive. Yeah?
I think the SWOG trial closed, if I remember.
Yes, it is. Shilpa said that, yeah.
Closed. I think the big question to me, Tom, I think all of them will be positive, but for EFS, the big question in my mind is what about OS? And the question is because adjuvant nivolumab got approved in August 2021 in the US.
Yep.
I think it was April 2022 in Europe. The question is, if the control arm of those trials, if they have exposure to adjuvant nivo and potential more systemic therapies as salvage in metastatic disease, would that potentially wash out any survival benefit? Would we have a potential risk of not having a positive trial?
Well, then those trials are going to be complicated because if the EFS analysis is complicated because patients are choosing not to have surgery and the OS analysis is complicated because of the control arm,
right,
then you might say, actually, maybe they're not all going to be positive. Petros.
It's going to be a risk, especially because of the adjuvant and metastatic therapies and patient selection of avoiding cystectomy.
I'm going to go back one. I want you to tell me EV Pembro, let's keep it simple. EV Pembro, EV Durvalumab, what's the path CR rate going to be? Shilpa, guess for me.
65%.
65%.
Agreed.
65%.
70.
70%.
With all the caveats we discussed before, between 50 and 60%.
So we're going to go a median of 60%. I'm up for 65. I'm going for 65 too. There's where I am. There we go. Okay, if it is 65%, then patients are going to come to clinic. They're going to say, I just looked at the publication. I've got them. I'm on the same drugs. There's a 66, there's a 2/3 chance that I've got no cancer left. I don't want my bladder removed. I think 90% of patients are going to do that. And I'm going to find it very hard not to tell my patients that, by the way, you're just about to have the biggest operation you can imagine, and there's a 66% chance that you don't need it. So the question is, how important is this trial here, looking at bladder-sparing approaches, and what was the issue going on with local recurrence of disease? Who would like to answer that question? Carla, would you like to?
I'm happy to answer that. Yeah, I mean, I think this is an important trial. That's the first point. The second thing is patients who had a clinical complete response, the majority of them opted to keep their bladder, not surprising there at all. And I think it's cool because a number of patients got adjuvant nivolumab, also really important. But what I feel with this trial and the retained study that was presented before it, we are still seeing a fairly high rate of recurrences within the bladder, and some of those are developing into metastatic disease. So I personally don't think doing nothing to the bladder is okay right now. I think we still need to consider trimodality therapy. Now, this could change with something like EV Pembro for truly seeing...
Or intravesical TAR agent.
Sure, yeah. I think that
that's where I think it comes in.
If we're seeing...
I think it's about local control.
That's what I just said.
I think so.
I know.
And I said that too.
Yeah. And I think that'll be the comparison, looking between something like TAR 200 and maybe TMT.
Okay, we've got a minute and a half left or so. This is a slide again. I wrote this a little while ago.
We have 5 minutes, according
5
to
minutes,
Brian.
yeah. I'm going to try and have a 2-minute break between the two. So this is curing most patients with muscle-invasive bladder cancer without surgery. This is aspirational. So T2 to T4, N1 disease at the beginning, systemic therapy, discussion about CTDN at the beginning. Either you do exceptionally well. We think 70% of patients are going to be in the green box. They're going to go observation, maintenance, immune therapy for a year. I think that's probably right. But that question needs to be answered, coming back to what Tony said previously. Do you need to have the adjuvant period as well? And then you've got this yellow period in the middle where some of the results look good, but it's not completely cleared. And then there's an issue about radiotherapy. Then there's the losers. I think there will be those losers, I'm afraid. And we do surgery on them, and if they remain ctDNA positive, I don't think we should be giving more of the same drugs. I think, if you've given chemotherapy, EV Pembro or Durvalumab neoadjuvantly, you've had surgery, you're positive, more of the same probably isn't going to, you should be maybe switching to something else.
But Tom, to your point, if they are ctDNA positive or cystopositive despite the systemic therapy, then instead of, why would we make them go through a big surgery? Probably switch to another systemic therapy.
So even then they're not getting surgery? I mean, that's quite radical.
Surgery there, right?
Sure, yeah.
They shouldn't be getting surgery.
So Petros, no, Andrea, far away. What do you think about that slide? Is it insane?
It's
And
very busy.
Yes.
But I'm following what you're saying.
Yes, which is unusual.
Systemic therapy and, assess their ctDNA and then do something local and keep the bladder. I mean, I think that is what we should be doing for our patients. This is what patients want. They want to keep their bladder. And if it's really up to us to design the right trials so we can do this.
And I
So,
think in
yes,
the
I
last
love this.
red box also TAR-200 plays a role.
In the red box too. Carla, what do you think about this slide?
Yeah, I like this slide. I think in the green box, I would like to see sort of a randomization between TAR-200 and concurrent chemoradiation.
And Petros, what would you do differently other than all of it?
I think the points are all well taken. The challenge is feasibility and accrual in this study. These are the trials we need to do.
Well, these are like 5 studies. Right?
Yeah, these 5 studies, of course, at least, right? Maybe more than that. But I like the colors, by the way. So I think that the first question we have, Tom and team, is how can we stringently define clinical complete response and correlate that endpoint with long-term survival? Is that a good surrogate? And I think we're getting some hints about this data. I think your approach is reasonable. I don't think we really know, to Silpa's point, if you have ctDNA positive disease, is that systemic disease, micromeds, do you need to change systemic therapy, or should we go locally? That's a question, and I think it depends also on what other systemic therapies we may develop down the road. Maybe more ADCs. Maybe we can have better biomarkers to piece that apart. By the way, the urine DNA is very promising, but it's not there yet for clinical utility. We need more data with urine DNA.
Okay, so we've got a couple of audience questions coming up in the last minute. Can we fire away with this first question? Is there a QR code that people can link to? Do I need to move it forwards?
Laurence, you can vote for me too.
Here we go.
So we can vote too.
I don't see why we shouldn't vote. Have a go. See how we get on. I'm going to vote.
Me too.
We can vote. I voted at ESMO in this discussion.
For your own discussions.
But Tom, I'm going to ask you this. What about dose-tensive-vac IO? We need to talk about that.
Well, there is going to be a dose-10-10-vac durvalumab phase 3 trial. Okay, can we close that one? Because we've got 1 minute left for our last question.
One more.
Okay, can we move to the next question? Is that possible? Okay, so would you give EV-Pembro for a patient whose cancer's progressed? So let's say you're giving durvalumab is the standard of care, and your patient progresses. Would you give EV-Pembro afterwards? Yes to all patients. Yes, but a 6-month gap since durvalumab, or yes, a 12-month gap. Pardon?
How about no?
Yes, or yes.
Okay. There's a flaw in the question. Look, if you think, should we re-ask it? Is it probably too late to do that?
Maybe people can raise their hands who would never do it.
Yeah, what about no?
What about
Are there
no?
no's? Oh, should we re-ask the question after the break, Brian? With a no in it? Yes, we're going to do that.
You can
Brian's
ask
going to be in charge.
EV-Pembro or just EV.
I quite like the question, but there does need to be a no. Yeah, I think it's a fair point. Do you know, on that bombshell, we've got 2 minutes left for the live stream.
You're doing good on time, Tom.
I've never seen Tom be on time.
Ahead of time.
We have a question which is fabulous.
Is this my one?
Dr. Campbell.
I'm very enthusiastic with the data. I still, what haunts me in my clinic are the patients dying with metastatic disease, bladder intact, bleeding, infected, fistula. That's still a major problem that we face. I think we can get some insight for the EV-Pembro patients, and maybe this is something we can look at in NIAGARA. For the patients that have metastatic disease, bladder intact, how are they doing in the long term in terms of their bladder control?
That's a great question.
Yeah.
Patients end up
Very
progressing,
symptomatic.
and we have to figure out what to do for those patients, whether it's radiate, whether it's TAR, whether it's palliative cystectomy in a subset. So that's a population that we still have to figure out.
I have often found that if the systemic therapy is working, that usually does help the local control. Not always, but it usually does. But in some cases, some patients do get in trouble, and we need better treatments for local control.
So more support to my wish list, Tom, to capture those patients in NIAGARA and report the data in the future.
We're going to round this up. Thank you for the question. We're a minute ahead on time. Thank you to the panel, and thank you to the audience for your questions. Thank you.
Thank you.